I'm Dr. Janet Wright, meeting today with Dr. Harlan Krumholtz. We're here to talk about hospital to home. Harlan, we have a problem with readmissions in this country.
Yeah, Janet, thanks for having me here. Anyone watching, I'm sort of informal and casual here today, Janet. Janet asked me to come over and talk about this. There's no question about it. We're kind of focusing on this issue of readmission now. There's articles that are coming out that are pointing us to the very high readmission rates and the variability around the country. There are national publicly reported measures now that are indicating that there's quite a breadth of rates across the nation's hospitals, and that all those rates are quite high. And the government's getting interested in this. It was even mentioned in Obama's report around at the turn of the year as a central focus, and Congress is putting this into bills. So, yeah, readmissions are hot. They're an area target for quality improvement, and they're an area we're really focusing on now.
And a large percentage of those patients getting bounced back to the hospital have cardiac problems.
Yeah, the cardiac area is an area of particular focus. For the national measures, 2 of the 3 national measures are in heart disease. There's one for acute myocardial infarction and one for heart failure. And these patients, we feel, are particularly vulnerable. And the rate for heart failure, which is 1 in 4 ending up back in the hospital within 30 days after leaving, is the highest among virtually all the conditions. So it's a large number of people get hospitalized with heart failure, but a whole heck of a lot of them end up back in the hospital very soon after leaving.
And a lot of those folks haven't seen a physician in the 30 days since they were discharged.
Sort of increasing interest in this issue about the transition from inpatient to outpatient status. And what we're discovering is that we have a lot of assumptions about what's going to happen to people when they leave, and that's not really fulfilled. We think that people are going to be able to get their meds and stay on them. We think people are going to be able to make appointments and keep them. We think that people have the information about the admission that's going to be with the doctor when they go see the doctor, and all these things, it turns out, when you look deeply, they often don't have appointments, they often can't get their meds or haven't bought their meds, or somehow they haven't understood what meds they should be on. And the information from the hospitalization, the discharge summaries, have not even been dictated sometimes when they do have appointments, so that when they are seeing someone, there's a whole discovery process that needs to take place about even figuring out that they were in the hospital or what happened to them in the hospital. So there's a lot of areas where things fall through the cracks, and as people are very in this vulnerable period, aren't necessarily getting the very best care because they're kind of left to their own, and the hardiest of them do well maybe, but a lot of them end up back.
There's a lot of room for improvement.
Yeah, it's remarkable. The more you kind of scratched on the surface, you see that we focused a lot on hospital quality, and we're doing a good job thinking about what's going on in the office, but leaving that person in that transition period where they're leaving the security of the hospital, everyone's looking after them, and before they've sort of reconnected with their doctors, where they've, are now have someone else who's connected and helping them and understands what's going on with them, they're kind of out there, they're floating and not quite sure. And all the education that we've done in the hospital, turns out, yeah, sure, they receive some of it, but when you're sick and there's so much going on, it's hard to process it all. So, they're leaving, I think, with a lot of uncertainty about what are they supposed to do next and how's this supposed to fit in. And these are all areas that we could concentrate on and improve, I'm sure.
Harlan, I know you well enough to know you can't define a problem or even live next to a problem without trying to come up with a solution. Tell our audience about hospital to home.
Yeah, so hospital to home is sort of this outstanding effort that's being undertaken here at the college in primary partnership with the Institute for Healthcare Improvement and a variety of other organizations. Well, what we're trying to do is create a resource for people who want to start focusing on this problem, especially with Congress's interest in this and the potential implications for reimbursement and compensation. There's going to be a whole lot of people who say, gee, I want to start looking at this, seeing if we can improve. And yet there are paucity places people can go to really get the scoop about why is this important, what's the issue about readmissions, are they really preventable, is this really an indicator of quality? What are the paths toward improvement? How do we even begin? What do we do? There's a whole lot of expertise that needs to be gotten in order for people to be in a position to make some strides. And what are the tools that we can make use of? And then how are we going to evaluate ourselves? So, the college has just been wonderful in stepping up and saying, gee, this is the next big problem we should help address. We did a great job with Door to Balloon. We've still got some work to do here. But readmissions are the area that we can help really energize and strengthen teams around the country and make a difference in. So this hospital to home is this, we call it more of an initiative than a campaign. It's an effort that's meant to help launch quality improvement initiatives around the country and to provide people the tools that they need to be successful.
Now, Don Berwick, I think, told us he wanted to be involved with this, would bring IHI along, but we had to have a specific goal. What's the goal of H2H?
Yeah, first of all, the idea that we got Berwick and IHI involved with us, I mean, it's a real tribute to the college and to this effort and to all the other partners that we have. You know, this co-partnership is really pretty remarkable, but it's true. When we went to IHI, they said, we got to be very specific about what you're trying to achieve. And so we said, you know what we really want to achieve is by 2012 to get a 20% reduction in the readmission rates for cardiovascular patients. And so what that translates into, if we're about a 25% readmission rate for heart failure, we're saying we want to shave 5 absolute points off that. We want to get down to 20. Now, 20 still means 1 in 5 are ending up back in the hospital.
Right.
It's still hard to change this, but we think it's achievable. And what we're trying to do is to inspire people to join us, to help bring together a critical mass of individuals who can learn from each other. Part of this H2H is about trying to create a learning community. Nobody knows all the answers here. And the answers that have been suggested need to be tailored for individual environments. For us to really make rapid progress, we have to be able to share ideas, share experience, and move together, take advantage of the wisdom of crowds here. And I really think we can do it. This is a wonderful platform to do it. And yeah, that's going to be the goal. 20% reduction by 2012 in this rate. Relative reduction of 20%. And I think it's possible, but we're going to have to work together to achieve it.
We've been talking with Harlan Krumholtz about a hospital-to-home initiative with the Institute for Healthcare Improvement. H2H launches later this month.